The last lecture and this talk also they go under the category of what I love to call boring but important, right? Like who's gonna pay for this and who's gonna administer this stuff, and it's kind of nuts and bolts, and maybe it's not sexy, although I think we're gonna do our best to make it sexy, but we're gonna talk about professional education. Speaking of standards for psychedelic medicine, we're not gonna talk about anything sexy anymore. We're talking about who's getting educated, who's getting credentialed, what the rules are going to be, who's making the rules, what are all the ins and outs. And my first question, and you guys are going to have to like jump for these because I did not write down who was getting what. Actually, let me introduce the people, and then they're also going to introduce themselves, and then we'll start with the questions. I am Julie Holland, and I am a psychiatrist and author and a last-minute pinch hitter as moderator today, but I will be emceeing all day tomorrow. I'll be Kelsey. And I am joined by NiCole T. Buchanan, PhD, CEO, Board of Psychedelic Medicine and Therapies, and Kelley O'Donnell, MD, PhD, Director of Clinical Training, NYU Center for Psychedelic Medicine. I'm going to have each of them say a little bit more about who they are, why they're here, why they care about this, maybe even a quick origin story if it's really quick, and then we'll get into questions.
Okay, I'll go first. So NiCole Buchanan, Board of Psychedelic Medicine Therapies, and I guess the quick origin story is, and this is a little embarrassing to say at this point given my growth and development over time, but I really came to psychedelics late in my life, a career, around 2017, and came into it more through the angle of biohacking, kind of how do we make humans better? How do I make myself amplify human ability? And was part of the 2019 MAPS training and had opportunity to be with really phenomenal people. I see Jace Filius and Hanifa and all these people. I think I saw Victor back there and Courtney, and really had this opportunity to be exposed to psychedelics through an equity lens, and it changed everything. And so part of why I'm committed to this work is because there's a lot of work to be done. And if we want to create a psychedelic ecosystem that is inclusive and that is doing the work in the way we need it done, then we need to broaden the group of people doing this work. And we need to make sure that we're embedding everything that we're doing with an equity and accessibility lens in order to really do justice to the society that we serve.
Lovely. Kelley?
I am Kelley O'Donnell. I'm a psychiatrist. My origin story is also, I don't know, nothing about me is linear, I suppose. I came to psychedelics after, pretty late in my training. I was in a lab at UCLA where I was getting my PhD in neuroscience. I'd already done 2 years of med school, and I thought, oh my God, I really might die if I have to, do one more thing in this bench, at this bench. And every sort of moment, I would say something like that to myself. It's like, okay, but I can go back to med school, I can become a psychiatrist, and then something. And sort of during that phase, I started hearing about the use of psychedelics in healthy volunteers, and then later in the cancer-associated anxiety and distress. And if there's one thing that is my bliss, it's talking with people about meaning. And it really seemed, so I'd been really interested in palliative care because death, or impending death, really gives people an opportunity to be thinking about those things, and they seem much more willing to do that. And it was so interesting to be reading this research that suggested that psychedelics were making them more open to that same thing. And so I got really excited in their potential to facilitate that kind of really profound transformational work at the end of life. And then went to NYU for my residency because I was on the research track, started working with Michael Bogenschutz and Steve Ross as soon as I was there. So now I am still there after residency. I had worked, I think, on 5 clinical trials, psilocybin and MDMA for various indications, Malikos trainer and supervisor. But I think I have a lot of thoughts. I think because of my origin story, psychedelics were not on my radar in high school or college at all. And so I have thoughts about the answer to that last question as well, and kind of what it takes. So hopefully today we will talk a little bit about kind of what it takes to be a good therapist, whatever your psychedelic
Wait,
background.
you're saying you have thoughts about the last question about whether you would refer to a practitioner who hadn't experienced the landscape prior?
I do.
Go ahead. What are your thoughts?
So I was a psychedelic therapist before I had tried a psychedelic. I became a psychedelic therapist and a regular therapist essentially at the same time because I started on Michael Bogenschut's trial of psilocybin-assisted therapy for alcohol use disorder. I started working with the group my first year, and so my second year I was starting, training as a therapist to be on the study. And I really think that everything about I think that my psychiatry residency training did not make me a good psychedelic therapist. I don't think my medical training did, but the fact that I studied philosophy and Western classics, and the fact that I love poetry and use it as a spiritual resource, I think those are the kinds of things. The fact that the world has this transpersonal dimension for me. I think all of that really is what matters. And I think that for some folks, they don't get that without psychedelics, right? Psychedelics are the first and maybe the only time they see that dimension exists at all. And yet I think a lot of our patients, and certainly participants on these studies, are suffering because they suffer the absence of that, the absence of the transpersonal, the spiritual dimension. So I think that as long as you have that transpersonal awareness, whether it comes from psychedelics or breath work or some kind of contemplative practice, then there's a lot of potential. And of course, I've done psychedelics since then. I don't think that it's made me a better psychedelic therapist. I think doing more psychedelic therapy has made me a better psychedelic therapist, just like that would be the case for any kind of therapist. But yeah, that's that.
Do you feel like weighing in, or should we just get into it?
No, she's got to.
Do you have thoughts? Do you have thoughts about this?
I feel I must now.
Please.
I'm a little more torn. I do think that there's something really essential about having experience in non-ordinary states of consciousness.
Yeah.
And, but we can do that in a variety of ways. I'm also very sensitive to the idea that there can be health constraints that make it so that someone can't engage in a particular substance, but can still be really good at offering care. But I do know that one of the challenges we see, and we see this across therapy in general, where the clinician doesn't have ample experience in the individual's life experience to offer quality care. And sometimes it's in the small things. I don't know to pick up or to follow up on this comment about the cultural experience they have because I don't recognize that that's even a cultural lens that informs the experience. Mm-hmm. And so when we have those gaps as the facilitator, as the provider, we sometimes do harm. Mm-hmm. And so my fear is that if you don't have ample experience to inform what the client is experiencing, then you may do harm through your ignorance, mm-hmm. even if it's purely innocent, mm-hmm. even if you intend to do nothing but good. Mm-hmm. What we don't know hurts our clients.
Mm-hmm. Absolutely.
Nice.
Well said, for sure.
I like that.
I will say, can I say one more thing?
No, sorry. Yes.
I'm going to do it anyway. Whenever anybody asks this question, I think that we should be making a distinction between a psychedelic experience and an experience with psychedelic-assisted therapy, because they are different, right? If you're going to be a psychedelic therapist and you go and you have your experiential ketamine session, and you think, okay, good, got it, figured it out, now I know what I'm doing, I'm gonna be good at this, they're gonna ask me if I've ever done this myself, I'll be able to say yes. That does not make them a better therapist from the next guy necessarily. And so that's a really important distinction. An altered state of consciousness is not the same thing as psychedelic-assisted therapy.
And in the reverse, just doing Molly in the club doesn't necessarily mean...
Exactly.
Right.
Yeah.
So who are the psychedelic practitioners that we're talking about here? I mean, can we sort of define who are these people?
I think we can look out and we can see a wide variety, but really we're seeing that psychedelic practitioners come from a whole swath of life experiences and professional experiences. So we are working with people in nursing and in medicine and in social work, and my field is clinical psychology, and we're seeing chaplains. Like the number of people that are coming forth that have an interest in doing this work is really quite astounding. And then, of course, we can't forget, where did any of us have the privilege of having access to these medicines. It's because for millennia, there were indigenous people, there were people that were nurturing the plants and nurturing the process that gave us this amazing gift. And so we have to also be thinking about what are the ceremonial practices, what are the non-medicalized practices that have given us this opportunity to have these kinds of discussions. And all of those practitioners are who we're talking about.
Mm-hmm.
I mean, I know, we've got prescribers who are, MDs or RNs or PAs, nurse practitioners, but then, and that maybe is a little bit more of a narrow pool, of just the prescribers, but the facilitators can be a really broad pool from all sorts of clinicians and master's level therapists and chaplains, and then there's pharmacists. Right? So it seems to me like in terms of the bottleneck, I know some of us are worried about there being bottlenecks where there aren't enough people trained. I'm wondering if this, this bigger pool that we're pulling from can help with the bottleneck. Do you have any opinions about this?
I got opinions about everything.
Oh, good.
Yes, certainly. And I hope that we don't think about it only as a way to help with the bottleneck, as though the most important thing is like get warm bodies in rooms, right? I think that this kind of broad range of people from different training lineages, from different cultures and everything, I think that's going to be really important for optimizing the safety and the efficacy of the treatments that get provided. So that's going to be crucial. That being said, I also think, and this is my bias as a doctor maybe, but I also think that the prescriber side doesn't get enough attention. Right? I've sat on lots of these panels, even in Denver last summer, and we were talking about therapist education. And so I asked if we could expand kind of the scope today to talk about practitioners more broadly, because it's no good to have a ton of therapists if nobody can safely prescribe the medicine, right? And there could be this fantasy that the prescription itself is algorithmic. Certainly, on the research trials, it's sort of like inclusion, exclusion criteria, check, 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 no, 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 look at the EKG, okay. It's not going to be that simple once this actually starts happening, right? We're going to have much more complex patients who are not all going to be able to come off every single medication. We're going to need prescribers, we're going to need doctors who are able to have a really careful kind of shared decision-making process with the patient, doctors who are keeping up on top of the literature. And I say that, they don't even have, right now, we don't even have the bare bones of that. The Hefter Institute and some generous donors, some of whom are in here, funded a 2-year sort of curriculum development grant that NYU and Hopkins and Yale have been collaborating on to develop just some very basic modular components to teach medical students and psychiatry residents, kind of just the basics of psychedelic medicine so far. And we're just finishing it up right now, and some of the stuff is already out of date. That's how quickly things are moving. And so post-approval, say, of MDMA, or as we get more information, from Australia, say, we're going to be learning more and more about harms, and we're going to need people who are keeping up with that and who are then disseminating that information. So I think that, I think ultimately we're going to be looking at psychiatry having a subspecialty in psychedelic psychiatry, like we do in addiction medicine or addiction psychiatry. But for right now, we really need to just get some people educated with, even MAP 1 and MAP 2, right? The 2 phase 3 trials of MDMA-assisted therapy. That I just think everybody knows that now, but that's because I live in this room.
Right. Can you talk to me about credentialing and accrediting, or talk to the audience? Please explain credentialing and accreditation and why it's important.
Sure. First, I think it's helpful to have a distinction in what we're talking about, because often the terms get used interchangeably, and they really should not be. Often when we're talking about accreditation, we're talking about accrediting, say, a training program, accrediting an institution like the Board of Psychedelic Medicine and Therapies, where the entity is accredited to then go and evaluate others' credentials or training, and then determine if those individuals should be credentialed. And so what we're doing at the board is we're going to be looking at the individual practitioner and looking at the credentials of that practitioner and establishing standards and expectations for things like training, education, experience, ongoing continuing education, and looking to see, do they meet that high standard for offering safe, ethical, knowledgeable care for individuals. And so that we're credentialing or offering a board certification for the individual, but there will be other organizations that then are looking at what's happening at the level of training programs. And our training programs meeting the industry standards and then offering those programs accreditation. So think of it as accreditation goes to a program or an institution, and board credentialing goes to the individual practitioner. And so why is it essential? Well, we've been talking most of the day, if you've had the pleasure of hearing the talks today, we've been talking about a variety of concerns: a lack of access, inequitable care, individuals in the public who are perhaps terrified. We live in this bubble in rooms like this where lots and lots of people are engaged and we're talking to true believers. But when you go and talk to the general public, there's still a lot of fear, a lot of concern, and those concerns are not equally distributed across populations. I grew up with the story of Lonnie, who came back from Vietnam and dropped acid once and never was the same again. And the entire community has been framed by these kinds of narratives. So we have a lot of work to do to ensure to the public that they can approach these medicines and these treatments and experience healing, safe care. And one approach we have for convincing the public that there is a standard in place, that this can be safe, that they can seek out particular practitioners for safe care, is through credentialing. So if we are going to convince the public that we have a mechanism for healing, we have to work within structures that the public understands, and credentialing is one of those processes. The other benefit of credentialing is that, at least while we're talking about insurance frameworks, the insurance companies are going to be looking to see, who should we be allowing on our panels? How do we go about deciding who is a safe practitioner? And we will have done that, a lot of that work for them. We will have done the vetting. We will be able to offer a safe place for individuals to look, and for insurance companies to further their vetting process. So I firmly believe the credentialing process is essential for us being able to offer accessible care, equitable care, and for expanding care to the total population.
Accountability is coming up, and I know I would like a whole conference on accountability. Can we talk about accountability a little bit, either of you, and like how that fits in, risk management? I imagine you both have things to say.
Absolutely, absolutely.
No, you get started. I still have to like calm down my nervous system anytime she like refers to the ISO report.
About the ISO report? Okay,
well, I mean,
so we're just gonna breathe through our noses, exhale longer than inhale, just take a few minutes, close your mouth. We're all going to calm down for Kelley. Accountability. I thought you were just getting worked up about accountability, because there's plenty there.
Yeah. Well, another piece, and this was brought up earlier, another piece that happens when things are criminalized is that people don't have a venue to go to when something bad happens. And the fact that they've participated in something that is illegal minimizes the opportunity they feel they have for recourse when something bad happens. So that's another reason why it's critically important that we move towards approval and that we have these mechanisms that demonstrate where safe care is possible. And another important piece of the work that we're doing with BPMT is there will be accountability. We will be a mechanism for people to make reports and to ensure that if there is a bad actor offering care, there's a mechanism for reporting that information. I'll also give a shout out to SHINE. I think I saw Erica Siegel over here, is another mechanism for reporting those bad actors in the field. And we need to have more of that. Credentialing is one mechanism for doing that. Of course, as we decriminalize and we legalize these therapies, that's another mechanism for doing that. And then we have to look at how are we creating structures for there to be teeth to that report. And I think so far, in general, we haven't done this particularly well. We can look at all sorts of practitioners inside psychedelics as well as out who have been identified as being problematic, and not much was done. And so we need to determine how we're going to make sure that we have teeth in the mechanisms we develop to censor those individuals who are not engaging in safe, ethical, and knowledgeable care.
I would say yes, 100%, that all makes sense. It's super important. I think we also need to be thinking about what are we accountable for? And who are we holding accountable for that and how, right? When we think about, like this idea of the bad actor, there are definitely bad actors. There will be more bad actors, definitely. But psychedelics are, they make everyone a little bit more vulnerable to interpersonal boundary crossings, which are not necessarily boundary violations. They don't necessarily cause harm, right? But they really open us up to these kind of ambiguous, ethically ambiguous spaces and behaviors. And I think that we're going to need to be accountable for educating the field and about ethics, because it's not simple. It's not as simple as saying, here's a code of ethics, now go forth and follow it. Not at all. And especially if you think about, having worked on these studies, you would be astonished, I think, if you haven't worked on them, you'd be astonished at just how much access these participants have to the therapists. I think they've always had my cell phone number and they've always used it, which is not typical for standard psychotherapy, and I don't think is going to be kind of standard of care in the future if this is going to be sustainable either, right? In fact, my psychoanalyst, like when he first heard that, he very high eyebrow raised there, right? Because for him, if it had been like that for us, that would be a boundary crossing. Again, not a boundary violation necessarily, but it would have been me stepping outside the normal kind of frame of our interaction. And there's always meaning to be explored in that. There are always ethical harms that can be caused, by those kinds of crossings, but also by not crossing. So I just think that it's so complex in a way that certain sort of inflammatory pieces don't really get at. And I really want us to be able to say, yes, we need to, get rid of the credentials of, licensed bad actors, but also we need to be able to really openly talk about how hard this work is, how the intensity of this work puts us all in vulnerable positions, and be accountable to ourselves and to each other for that too. So don't have sex with patients, but also,
yes, I think
say that.
Some things are obvious, and also,
think
to your point about sort of broadening how we think about accountability, like of programs. How are they accountable when it comes to, being equitable? Are they what values are they accountable for? That's really important. There was a talk earlier today that was kind of put your money where your values are. It's all action. So what, if you're one of the people in the room with the money to be doing something with, sort of what psychedelic medicine as a field becomes is going to depend in part on what we put money into educating people about, right? Because our value system is embedded in our education system. And so if equity is embedded in that as a fundamental principle, and then people give it money, it's going to become part of this generation of psychedelic medicine. Whereas if instead it's a more pharmaceutical model, it's just not. It will, the kind of psychedelic medicine that I've been practicing over the last several years will only be for the wealthy, period. So accountability broadly defined, I think, is something I care about.
Can I add one more quick thing?
yes.
And this is also why it's really critical, as I talk to people in this room who are dedicated to these issues, it is critical that we do this work ourselves. If we don't establish the accountability mechanisms, if we don't take this on, others will do it for us, and they won't understand our field, They don't understand the nuances of the work that we do, and we will become subject not only to others' rules, but then when there are complaints, we will be subject to their punitive measures when they don't understand what we did in the first place. So we have to have spaces like BPMT where we're going to be taking in those complaints, or we're going to be adjudicating them, because we actually understand the work that we do. We understand the work that all of you are doing. And if we don't take that on, if we allow others to come and dictate our field, we will look very different by the end of that process.
What do you think is necessary? Whoop. It's a very good point. What do you think is necessary in the larger sort of psychedelic ecosystem to ensure safe and effective care? What do we need to do?
We need to do so many different things. One, I have to say, I loved your ending comment. We need to put our money where our values are. We need to make sure that we're putting funds into those places that are really focusing on creating accessible, safe, equitable care, where the focus is on what are the ethical and knowledgeable practices that we want to perpetuate in the field, and that we're really then amplifying those voices and those efforts, and not just reverting to models that are focused on one pathway, that are really for one type of practitioner, and that don't really give the kind of nuance that we see when we're actually working with real people. We absolutely have to have these accountability centers. And those accountability centers, I want to emphasize, it doesn't always mean that somebody has done something bad, but it's also a mechanism for practitioners to consult with other professionals who understand the field and get help with, how do I engage in this work in an ethical manner? How do I manage this potential conflict? How do I manage aspects of, say, touch that I might not be very comfortable with, but a client is longing or asking for? So our accountability mechanisms and having organizations that have embedded equity in their access and training, those are going to be the ways that we save our field. And if we bypass that in an effort to go with what is expedient, what is known, what we're used to, we're going to have these same failures in the systems and how they provide care and services.
You know, you mentioned if we don't do it ourselves, other people are going to do it for us. But the truth is, there are going to be other people doing it for us. I mean, we should talk about who is ultimately going to be regulating or governing credentialing and accreditation beyond the board, like FDA or any other sort of government bodies. I don't know. I got it right here. We got to talk about it.
Well, the answer, whatever
it's
the
question
notes are
number
underneath
4.
there, it probably says, like, ask us next year, right?
It's totally, here's one of the answers to my questions, in quotes. It's complicated. Ask me next year. So I guess the point is that, you know, like neuroscience, like psychedelic science, we are building things as we're moving along. And it's not really clear who's going to be the governing bodies. I'm also curious about what the board versus PMMA is. That there's like a psychedelic medicine board that isn't. Are there 2 boards, or is that my imagination?
She's thinking about APA.
APA?
APA used to be, right?
Is there just one board? Am I bringing up something you look like we shouldn't be talking about this?
That is not the impression I am trying to give.
Okay. Is it my imagination, or are there 2 sort of boards? Okay.
We are
the board is the
that
board,
are doing that.
but there's a psychedelic medicine group.
So what when
PPA.
So NiCole was saying, you know how you can credential individuals and you can credential programs,
yes,
right? So I think that the APA folks were I don't know, somebody here knows better than I do. Like,
Megan here?
Is Lynn Marie Morsky one of the people that I'm thinking of? Boy, this is not going
APA was
well.
more like what are we teaching people, right? Like, what are we teaching people? What are the modules like, et cetera, et cetera? I think of it a little bit like the board of psychiatry and BP and whatever that thing is.
The board of psychiatry and neurology.
Or it's whoever does the accreditation of residency programs.
Okay, I understand what you're saying.
And then the board is who we have to take a test from.
Yes.
Right, well, it's like being board certified in psychiatry. And what you're talking about is that there could be a subspecialty in psychiatry eventually, which is psychedelic psychiatry.
I think I think we'll have to.
And you would take a board exam for that.
Yeah.
And,
Yeah, it'd be 2 boards.
and it would be very challenging because the information is changing.
It is
all the
changing.
time. I'm going to open it up to Q&A since my questions aren't really going anywhere. So if anybody has questions, I'll look here also. This is when the boomer in me comes out. I'm like, I can't even turn this thing on.
While you're doing that,
Honey,
if I could
do
go
you know
back
what
to an earlier comment when we're
Let's see what
talking
the
about prescribers,
Oh,
this is something we've been really grappling with, is how do we bring prescribers in? Most of the training programs to date have really been focused on the presumption that the person wants to be in the room facilitating the session. And so I agree, part of what we need to do, most of the work, most of the zeitgeist moving forward has been around you're a facilitator, you're gonna be in the room. And this idea of what do prescriber needs is a question that's only newly being asked, and we definitely need to be exploring in much greater depth. We need to understand what those dynamic needs are going to be, and how do we create a process around educating this group and having a team focus in how we're offering these in systems of care, and making sure that there is a mechanism for both the training as well as the credentialing for those individuals who perhaps have no desire, it may not be any part of their plan to actually facilitate sessions. And right now, almost all of the energy and training has been put in how to be an effective facilitator in the room, and we need to do more that helps us differentiate those two groups and provide a mechanism for prescribers to be at the table and credentialed.
Yeah, nicely said.
One of the questions here I think is interesting is could the accreditation process actually get in the way of more access to psychedelic-assisted therapy?
There's definitely an argument to be made for that. There's a definite argument by having this accreditation program. At first, there's going to be costs associated. You're going to have to be able to vet your credentials. And at least in our first phase, we've been focusing on those who have either a licensable area. So maybe they're in social work, maybe they're in medicine, but they have another body that has already done the first part of that vetting. And if we leave it at that, we will absolutely be getting in the way of creating a healing framework that extends to all of members of our society. So we have to be thinking beyond that. If we stop there, we're going to be doing a disservice. But there's complications that are going to be involved in having accreditation and certification. Many of us in this room have done at least one training program. It's not inexpensive to participate in the training process. So what I would argue is, rather than stopping the conversation at credentialing or accreditation is a barrier to equity and access, that we then try to dismantle the barriers to equity and access directly. So we look at how can we facilitate more individuals being able to participate in training? How do we ensure that people are able to be in training where equity and access are a focus, where they're learning what they need to do good service with a vast population of people? And most of us, again, if you've been through the programs, there's not a lot of training on how to do a really good job with people that are perhaps systemically marginalized, multiply marginalized. And so I look forward to the day when all of our training programs really have that focus, and we've created an infrastructure where those individuals who have been subject to marginalization have equal access to those programs and that training. So we have the scholarships, we've reduced the costs, we've addressed the other barriers to people being able to adequately participate, and we've brought in then, in doing so, we've created also access for populations that have shunned these medicines and these possibilities. Because when people come into a center and they see people that look like them offering services, if they say, well, I can go and I can work with a queer woman of color and that's what I need, and that person's been trained, then we have expanded access. And I'll tell you, people talk. So when that one person has this experience and they know that this space has practitioners like them and can bring access, and they got good quality care that was knowledgeable and ethical, and centered on who they are as a person and understood their concerns, that will spread like wildfire. We will do such a wonderful benefit to the field if we begin to make sure that those training centers prioritize these issues, that we have created a larger ecosystem that's prioritized these issues, and that we make sure that the practitioners we're training can serve the vast communities that we intend to serve.
Yeah. So the idea is that we're going to need a lot of facilitators soon, and it's gonna come quicker than we think. And there's a couple of questions here about that. I mean, one is that there are already maybe thousands of facilitators that have been trained in some capacity or another, or they're underground facilitators. What happens to all of these people? They all have to sort of go through some sort of a credentialing vetting process. I mean, if they've already, like, could it be that we just say, okay, if you've been through MAPS training or Fluence training or CIIS, we just like list the training programs that we already know do a good job, and so if you've been through those training programs, then you're on your way to being credentialed?
So something that I get anxious about is when people say that they've been trained because they've done some didactic trainings. Maybe it included some role plays. Maybe there was a ketamine session. Now they've had their psychedelic experience. I'd be worried if then they go over to NiCole and they're like, I'm ready to take my test and be credentialed now. That's not how we do it in psychotherapy. That's not how we do it in medicine, in any field of medicine. Right? I graduate from med school with a medical degree, MD. I can call myself doctor, but I'll be damned if any of you would want to send your parents to me, right? I have to then undergo a multi-year apprenticeship in which I am seeing patients, working with patients, having clinical supervision, right? I really look forward to the day when all of this is embedded in, regular institutions as well. There will be more opportunities for that to be happening rather than just these standalone institutes. But I'm glad that so many people have the enthusiasm and are ready to kind of, be going when things get prescribed. But I think that we're going to need a lot of supervision of them. And I recognize that that's kind of an uncomfortable word. And when you were talking about credentialing, the word that kept coming up for me was gatekeeper. Who's gate? Sorry. He probably wanted me to take off my earrings before. The word gatekeeping, right? And again, here's where values come in. We can't say there are no gates. We do want, as you said, we have to regulate ourselves, but who's the us in that kind of comment, right? Again, we have to be thinking about what are the values that are driving each of these decisions. When I'm a gatekeeper and I say yes or no, what are the values driving that? Who's left out when I make that decision versus that one? Who's welcomed in who might not otherwise be? And so I think that we really need kind of post-approval, as these things get rolled out, we really need those folks who have the didactic training to have opportunities to be practicing, but still in a supervised setting. Because again, whatever you can learn in a PowerPoint or in a Q&A after a really great role play is just barely scratching the surface of the nuances of doing this work safely and well. And so I'm all for these programs. I teach in a number of them, and it is step one. It is not the final step before before people kind of hit the ground running.
Yes, and any credentialing program that took you merely finished a program and now you can get that stamp of approval, you should be very concerned about. Mm-hmm. What we are creating is going to prioritize what kind of experience have you gained? Mm-hmm. How have you gained that experience? Because we don't have credentialed providers, we can't demand you've been supervised by credentialed providers, but there will come a time where there is a vast enough community that will probably be one of the things that come into play. But absolutely, we want to have a comprehensive look at how individuals can function in this role. So you've been vetted and have gone through a program. You've demonstrated you've done that work. You've now engaged in supervised experiences. You've accumulated enough experiences to demonstrate that you have a higher standard of knowledge and experience that now warrants or justifies board certification. And as far as the numbers, just to throw this out there, the PSFC landscape report said we're going to need 55,000 to 100,000 newly trained psychedelic-assisted practitioners. So we're at the very beginning of a nascent field that's going to have broad-reaching impact, and we need to put the infrastructure in place now to ensure that that rolls out in a way that we all remain healthy and solvent.
And if
when do you think credentialing could start? Like, how early could this process actually begin?
If I had all of the money in the world, I think we could have
money,
this done by the end of the year. We are moving quickly, but we're doing it on really limited funds. So yes, if you are interested, please talk to us, BPMT, the Board of Psychedelic Medicine and Therapies. But even despite some of the infrastructure challenges, we are moving forward, and we are making great progress. Many of you in this room may have already took our job analysis survey, the largest survey of psychedelic-assisted practitioners to date, which is informing the development of the credentialing test and items and our overall credentialing program. So we are moving this forward and doing so with diligence.
You know, this is not an audience question, but I'm just kind of curious. For the people who have been underground practitioners for decades, is there a way that they can get legacied in without going to a training program? Will there be any sort of a test they can take or some way that they can prove that they've got a lot of cumulative knowledge?
Yes. One thing I would encourage is for everyone to go to our website and look at our lineage and legacy page. So we are looking at, helping to create the community for lineage and legacy providers, and asking and inviting in groups to help us figure out the pathway for credentialing this group. And I've had conversations, some people say, well, this group can't be credentialed because insurance won't pay for them. But those are two separate discussions. Part of what happens when we create a credentialing pathway for our lineage and legacy pathways is we interrupt what's happening now, where we have medical providers, we have licensable providers, where they're going to have a pathway to legally providing care, and we will have left the practitioners that brought us to this space to practice in criminal settings, where they can be harmed, they can be criminalized for the work that they're doing, which is what got us to where we could do our work. So even if insurance does not say we are going to reimburse this group of people, there is power in creating a mechanism where they can practice in a legal context. And that is one of the many obligations we have as a field. And I'll also say, if we are in this to create a healing environment for all populations, then that's also necessary. Because not everyone is going, and this was also said, I'm not saying anything this was said earlier, not everyone is going to resonate with a medical model. There will be many individuals who perhaps they wouldn't qualify under a medical model, but also it may not resonate with what they need and want. So if we are truly trying to create a healing framework for society, we have to make sure that we don't leave this group of practitioners behind. And we owe it to them. We have to do that work.
Dr. O'Donnell, any parting words, any final thoughts?
Don't forget about doctors and NPs and PAs, and we really do need to keep working to educate them, to disseminate, to outreach and advocacy, and also paying for ongoing research once we are looking at more complex patient populations with more drug-drug interactions. These are all going to be really, really important things. And then number two, to those of you who have done the therapy, the various didactic programs, hooray. You can already be practicing in a psychedelically informed way now without drugs, period, right? We're talking, like all of I'm involved in 3 different programs, and at the end of the day, all of them are rooted in a humanistic psychological framework that centers the individual's own innate capacity for healing and wellness, right? And that aims to empower the patient and foster the development of their autonomy, while also not saying everything is psychological. It has a transpersonal dimension to it, allowing for non-ordinary states of consciousness without pathologizing them. You can be doing this all right now. So please be practicing with the folks that you're already seeing. Again, like, I mean, I do with all of my non-psychedelic patients. I feel like I'm essentially the same person as I am with the others, right? Because the psychedelic-assisted therapy isn't just the dosing session. It's the whole package. And so who you are and who you're bringing, to, the whole spirit with which you sort of orient yourself to your work is something that you really can be bringing now. And so, I know you want to, like some of you are sort of chomping at the bit to get going. So do it. Get going.
All right. Thank you, Dr. Buchanan, Dr. O'Donnell.
Thank you.
Thank you.
Thank you, Dr. Holland.
Lovely.